So, Dr. Rodriguez, have you seen the same thing in your practice with your patients that have had the COVID vaccination?
So the answer is yes. I have to say that people with Parkinson's are very resilient, right? And they have been able to tolerate meds well. There may be some reactions as demonstrated in the study, but I have to say that uh, most, if not all of them, tolerated very well. I only have one patient that I can remember that she just complains of a little bit of lingering fatigue
Right.
after the vaccine, and she doesn't get infected with COVID. So she attributes this to her vaccine, but other than that, everybody tolerated well.
Yeah, I agree. I agree. It was really quite surprising. I observed this even within the first month that many of those that had concerns about the vaccination actually many of them had almost no side effects from any of these vaccines that are out in the market. Okay. Another burning question submitted by the audience: are there certain foods to avoid if you have Parkinson's? And I kind of tell my patients that there's really no special diet for Parkinson's. I tell them though to avoid animal protein too close to levodopa. So I tell them take your levodopa first, and then wait at least half an hour, and then you can take all the meat that you want, all the animal protein, but don't take your levodopa with milk, for instance, which obviously is dairy and therefore has animal protein as well. And then for patients that have severe tremors, I tell them to watch out, their caffeine intake and medicines that can stimulate them. So anything that's stimulating, whether it be a substance, a food item, or some other drug, or even some supplement, can worsen their tremors. And then if you read the literature, there's many food items that they suggest, albeit very weak evidence. There's really no direct cause and effect, but there's some association, maybe some hints that maybe certain food items may not be very good for Parkinson's, not necessarily harmful, but may not be very good for Parkinson's. And this can include cheese, yogurt, milk and dairy products, excessive alcohol, canned foods, especially those that use aluminum cans, fried food. If you do fry your food, they kind of prefer maybe olive oil or virgin coconut oil instead of corn oil or canola oil. And then diet soda with aspartame and too much red meat. Um, and then another burning question that was submitted by the audience would be: are there natural sources of dopamine? And I do understand, that, and I'm pretty sure Dr. Rodriguez has the same experience as well, that some patients, just want to go natural, right? They want to go organic. And the question is, are there certain natural sources of dopamine? And I think you did mention one of them a while ago in your talk. I was listening. Correct me if I'm wrong, but you did mention fava beans as a natural source. And so the answer is yes. So there are natural sources of levodopa or L-dopa, but there are also natural precursors also of L-dopa or levodopa. And again, Dr. Rodriguez mentioned fava beans, but how much fava beans do you need to be equivalent to 1 tablet of levodopa, which is 100 milligrams? So half a cup of your fava beans is equivalent to 50 milligrams. So in which case, 1 cup of levodopa, or should I say 1 cup of fava beans is equivalent to 1 tablet of your 25/100 levodopa, carbidopa levodopa. So that's a lot of beans, right? Which means, you're taking a dose of levodopa, carbidopa levodopa of 1 tablet 3 times a day. So it's 1 cup in the morning, 1 cup at lunch, and 1 cup before dinner. That's a lot of beans. And of course, we know what happens when you have a lot of beans, right? You get very gassy. So it causes flatulence and gassiness. So it's probably it's a good rich source, but be prepared, for the side effects. But if you take any more than 1 tablet 3 times a day, boy, that really is a lot of beans that you have to consume. And not everybody loves beans, to be honest. And then I talked about the precursors of L-dopa. So the precursors are the amino acids tyrosine and phenylalanine, and without going to details. But What food items therefore have this phenylalanine and tyrosine? So bananas is number one. Very rich in tyrosine. So of course, all of us eat the banana, itself, right? We don't eat the peel. But mind you, if you look at this table, if you were to compare the amount of tyrosine in the peel, the banana peel versus the pulp, it makes you think that maybe you should be eating the peel rather than the pulp, because the ratio is like 1:10, if not 1:50, in terms of the amount of tyrosine in bananas that the peel has in comparison to the pulp. There was one question from the audience. What about chocolates? Are they good for Parkinson's? Well, dark chocolates have been shown to be rich in phenylalanine. Again, this gets converted to tyrosine and eventually to dopamine. But again, you need large amounts of it, which obviously you're not going to do. So any of these food items that have, are natural sources of dopamine or the precursors, you really need humongous amounts to be equivalent to the amount of dopamine that you may need even in the early stages of Parkinson's. So I would think that you can supplement what you take, with the levodopa, with this dopamine-rich foods, but ultimately you really need, if you have significant symptoms and you're levodopa responsive or levodopa dependent, you really need the real stuff. And just make this, these supplements and food items as an ancillary or a measure in addition to what you take. Now, to me, the most powerful natural source of natural levodopa is Mucuna pruriens. So in fact, there was a study, or there's even more than one study now that tried to compare the effect of mucuna versus synthetic carbidopa levodopa, and they found out that mucuna seems to have a faster onset and longer duration of action. It seems to lead to less dyskinesias. It causes more nausea because it is native naked levodopa. And if you remember Dr. Rodriguez's talk, he talked about syn-emet without emesis, without vomiting. So it's the carbidopa, that extra ingredient that prevents the peripheral conversion of your levodopa to dopamine before it reaches the brain. And it is this that prevents the nausea. And mucuna doesn't have that. It only has levodopa. It doesn't have the carbidopa, and therefore there's just more nausea with this in comparison to your synthetic carbidopa levodopa. But you can give patients crackers. You can give carbidopa. You can give it with some anti-nausea medicine like ondansetron. And the other thing that I kind of don't like about mucuna is that it's not as regulated as L-dopa, and therefore across these suppliers, you really don't know how pure the mucuna is and just how much L-dopa it has. It's like the CBD oils or the CBD/THC things you buy in the market. Not every CBD product or THC product has the same purity and the same amount of active ingredients. Same thing with mucuna. You really are not sure just how much each of this compares to the other. But for instance, for the mucuna powder, you need about 7 grams, and trust me, that's a lot of powder. 7 grams of mucuna powder to be equivalent to 250 milligrams of levodopa. But it also comes in tablets and capsules. And the other thing that's not good about mucuna, aside from the higher incidence of nausea and vomiting, is that it's not covered by insurance. It can be pretty expensive. And I have patients that really are dead set are not taking Western medicines. They really stick it out with mucuna, and they just spend oodles and oodles of money every week, every month that they invest in mucuna. But I'm going to show you a video of a publication on that was published in a very prestigious journal called Neurology. So this is a patient in the off state. And you see that she shuffles, she has pulse instability, she has a tremor, and this is 19 minutes after taking a hefty dose of mucuna. The tremor is gone, she's able to stand up, she walks. There's a little bit of dyskinesias, which I see even in patients with pure mucuna. So just because you don't take levodopa doesn't mean you'll not develop dyskinesias. You will develop dyskinesias with mucuna pruriens. You have any thoughts on that, Dr. Rodriguez? You have any patients that have come to you and say, I don't want levodopa, I don't want your rosadonine, I don't want, your Western medicines. What can you prescribe me?
So it is very frequent, and I actually respect it, and I understand what how they feel, or that they have a particular philosophy. And but the main thing that I try to explain them is that obviously all the recommendations I am going to give them have to be evidence-based medicine. Just
Sure.
because we practice medicine, we have a license, and there are certain standards that we have to follow. So every medication that I will recommend to my patients are that there are double-blind placebo-controlled studies that show this stuff helps, and they have been tested by experts in the management of people with Parkinson's disease. Now, having said that, yes, supplements like Mucuna pruriens, there are levodopa, and people are going to expect some benefit. There is a plant in Hawaii, I forgot what the name is, but people eat it and they can get dyskinetic as well, and they can have
Wow.
hallucinations. And people need to understand that enough Mucuna pruriens, can give you hallucinations, can make you have nausea and vomiting. And we have a doctor in our area that he's a natural medicine doctor, and he actually sees people for free.
Wow.
Yes, but in exchange, they have to buy the products from him, right? And it comes to about, so I have a patient who she's a nurse, and she spends between $600 and $700 a month,
Yeah.
and she has violent dyskinesias, and they develop all the side effects. So I try to explain people that at least with the medicines that we have, we know how much you're getting. There is a particular measurement. However, it's not like I'm going to tell one of these patients, don't come here. If you don't want to take one of my medicines, don't come here. No, I will work it out with them. Just like for nausea and vomiting, we try ginger candy and that kind of things. I don't have any problem using this. However, people need to understand that we don't know what the quality of the product is. I don't know how they are measuring the content of the active ingredients. So they have to understand that there's a challenge there.
Absolutely. Yeah, I echo those observations as well. Okay, another question from the audience: can you get Parkinson's disease if you live in a small city surrounded by cornfields with no fences? I walk next to and into such cornfields regularly while walking my dog. So the answer is absolutely yes. So if there's one strong risk factor for Parkinson's that Dr. Rodriguez and myself routinely ask all our patients that we first see in my office, especially if we make that new diagnosis of Parkinson's, we ask them, well, were you ever exposed to pesticides when you were younger? We're not talking about just every now and then you spray some pesticides, to your little garden in your front or your pocket. We're talking about living in a farm. We're talking about having grown up in a very rural area where they sprayed pesticides on a regular basis. So this is one of the strongest risk factors for Parkinson's. And in fact, when scientists do studies on Parkinson's and they create animal models to test new Parkinson's medicines, how do they induce Parkinson's in animals? One of the easiest way is to introduce pesticides into these animals, and they soon develop Parkinson's, and then they test the drugs that they want to test on these animal models. And in fact, here in my neck of the woods, I see a lot of vets, and whenever I hear the word veteran, I kind of ask them, okay, were you in Vietnam by chance? If they're in their 70s or 80s, and a good percentage of them, if not more than half of them, will say, yep, I was a Vietnam vet. I was exposed to Agent Orange. And whereas in the past, they used to just acknowledge that it was just pure Parkinson's disease that was associated with Agent Orange. Nowadays, the VA is also acknowledging that the so-called atypical Parkinsonian syndromes like multiple system atrophy, or even dementia with Lewy bodies, or progressive supranuclear palsy are potential atypical presentations or Parkinsonism that may be associated with pesticide exposure. Okay, and then there's another question from the audience. I've been reading about the benefits of vitamin B1, which is thiamine, when taken with carbidopa levodopa. What is the doctor's opinion on this therapy? Okay, so B1 thiamine, what is its purpose? It helps the cell utilize glucose for energy. But what are the typical, patient populations that we think about, that Dr. Rodriguez and I think about when we think about low thiamine? When will we measure low thiamine? Which kind of patients are this? So number one, top alcoholics. So whenever we see, an alcoholic, a chronic one, they're wobbly in their gait, they have neuropathy, they have dementia, they have problems, learning new things. We also think about thiamine deficiency in patients with GI disease, irritable bowel, GI resection for whatever reason, our HIV or AIDS population, or those with poor diet. But are Parkinson's patients notorious, outside of being an alcoholic, outside of having GI disease, outside of having AIDS, outside of having poor diet? Are Parkinson's patients typically low on thiamine? And the answer is no. No, they're not. However, having said that, there are a few studies that seem to show an association between low thiamine and frequency of Parkinson's in the general population. And so there have been two small open label studies of injecting high doses of thiamine. Although these were not controlled studies, there was no placebo. It's very important when Dr. Rodriguez, encouraged the audience to participate in studies. We're talking about this placebo-controlled, double-blinded studies, which are really comparing patients that that receive the real drug versus placebo, and then whoever's gonna evaluate the patient is blinded as to which patient received which. But these studies on thiamine though are not blinded at all. So the question is, is there a placebo effect? So at this point, should Parkinson's patients routinely take thiamine? And my recommendation is no. However, if you, as I said, if I think you have neuropathy and you don't have diabetes and you have Parkinson's, this is probably one of the things that I will test for, the B vitamins, and I include B1, B6, and B12 in particular, and folic acid in my blood test to measure. And if you're low on thiamine, then so be it. Then we give you some thiamine. Now, a relative of B1 is B3. So there, again, another question from the audience. Would taking nicotinamide riboside be helpful in slowing progression of Parkinson's? So I'll call it NR since it's a mouthful. So NR is a form of vitamin B3, but the more common form that you guys are probably more familiar with is niacin. So niacin is the most popular form of B3. So this is found in fruits, veggies, meat, milk, and yeast. And you need B3 to repair damaged mitochondria. And is there evidence for damaged mitochondria in Parkinson's? And the answer is yes. And so the mitochondria are the power cells. They're the batteries. They're the power stations of the cell. So imagine your car having a poor battery. The car will definitely stop working if the battery doesn't work. And that's exactly what happens, we think, in Parkinson's. There is mitochondrial damage. As to whether it is the initial thing that happens that leads to Parkinson's versus, a bystander effect, meaning it is the effect of other things leading to damage to the mitochondria is still being debated and studied. But ultimately, if you have poor function of mitochondria, this leads to degeneration of cells, including dopamine-producing cells. Ergo, the production of Parkinsonian syndromes, including Parkinson's. And there is evidence that B3 can reduce inflammation of the brain and spinal cord. And now there is an ongoing trial. It's pretty huge in Norway, where B3 is being studied the most for Parkinson's. And then lastly, while we're in the theme of the Bs, another question: what about B6? Is it harmful or useful for Parkinson's? So I'm gonna first show you and try to simplify this. First of all, B6 is a very important vitamin because you need it to convert L-dopa, whether it be from natural sources or external sources, synthetic sources, to dopamine. So here's L-dopa, and then here's the dopamine, and then the conversion is through an enzyme called dopa decarboxylase, which only works if you have B6. So if you're low on B6, no matter how much L-dopa we give you, whether it be natural L-dopa or synthetic L-dopa, it will not get converted. So you need B6. Let's start with that. Having said that, you want the conversion of L-dopa to dopamine to occur in the brain. It has to first cross the so-called blood-brain barrier. So if you don't want the conversion to occur inside the blood vessels or in your organs, you want it to cross first, go to the neurons, the brain cells, and then there the conversion. Ergo, there is this question as to whether if you give too much B6, will you foster and accelerate this peripheral conversion of L-dopa to dopamine even before it's able to cross the blood-brain barrier? So dopamine cannot cross the blood-brain barrier, but L-dopa can, because there is a carrier for L-dopa, but there is no carrier for dopamine or a transport carrier to transport dopamine across the blood-brain barrier. So you want the conversion to occur in the brain. So back to the question, is B6 okay in Parkinson's? The answer is yes, because now we give levodopa, not as naked, levodopa, but we give it the carbidopa, which is Cinemet or Cinemet. Or if you happen to be in Japan or in Asia or in the Philippines or Canada or in Europe, there's Madopar, which is a combination of benzerazide and levodopa. And the carbidopa or benzerazide prevents the peripheral conversion of L-dopa to dopamine. So, and therefore, even if you give B6 to these patients, there is no danger of that, acceleration of peripheral conversion or premature conversion of L-dopa to dopamine before it crosses the blood-brain barrier. So, and then this is not based on hard science, but many experts have said maybe the upper limit for B6 should be about 25 milligrams per day. It's probably also best not to take it together with your levodopa. So if you take a levodopa before meals, then you take your B6 maybe before you sleep or somewhere in between the doses. Don't give it together with your L-dopa, especially if you're taking doses of 25 milligrams or more. And also, B6 is one of those vitamins that if you have too much of, can actually cause some damage. It is actually a cause of small fiber neuropathy. So too much B6 in the order of 500 milligrams or more can actually cause small fiber neuropathy, which presents with burning, in your hands or feet, or numbness or tingles. And also, low B6 seems to be a predisposing factor for patients to develop Parkinson's. I think, correct me if I'm wrong, Dr. Rodriguez, but in patients with intestinal levodopa, I think B6 deficiency is one of the things that we look out for, especially those that develop peripheral neuropathy, right? When they have DOPA.
That is correct, yeah. So I always recommend my patients to supplement with a vitamin B complex whenever they are on intestinal carbidopa, levodopa. There's been quite some research trying to figure it out. We really don't know exactly what it is, but that's my suspicion.
Yeah, I agree. And then just as a last comment, while we're on the subject of B12 also is very important, and that B12 deficiency can actually worsen your Parkinsonian symptoms or can cause frank Parkinsonism, especially it's pretty profound. So one of the things that I look for, especially in young onset Parkinson's patients, I almost routinely, or even in my Parky patients that suddenly have some worsening, I do measure B12 and the rest of the B vitamins. Okay, here's a relatively long question. My mom has Parkinson's. She took levodopa, then she had severe tiredness, stiffness, and abdominal pain. Her doctor changed her medications many times, so she still had the same side effects without improvement of her Parkinson's symptoms. We don't know why this happens. So in the old days, before we had tests to confirm Parkinson's, before the DAT scan, before the skin biopsy for alpha-synuclein, how did your doctors confirm or try to strengthen the diagnosis of Parkinson's? By giving you levodopa. So if you don't respond to the maximum tolerated doses of levodopa, then that's a red flag. And you start thinking about the so-called atypical Parkinsonian syndromes which again Dr. Rodriguez alluded to briefly in his talk. But L-dopa or levodopa should be effective because in Parkinson's you are deficient in dopamine, and if you're not levodopa responsive, of course, that presumes that you give them a good enough dose. And we heard from Dr. Rodriguez just how much he pushes the dose. He pushes the dose to 750 milligrams or 900 milligrams. And if the patient really doesn't respond, outside of the severe tremor predominant Parkinson's, chances are patient has one of these atypical Parkinsonian syndromes, which, mind you, can also have abnormal DAT scans, although the chances of the normal DAT scan is higher, and also can have negative skin biopsies for alpha-synuclein. You have anything to add to that, Dr. Rodriguez?
No, I think that probably that's one of the reasons for a lot of frustration, because many patients or caregivers are comparing their loved one with other people, right? And when a person is having a Parkinson's plus syndrome and it's not responding to the medicine, obviously there's a lot of frustration there. So, it is very challenging, but at least knowing what we're dealing with helps, and at least give us an idea of what to expect.
Absolutely. And then lastly, this is, I think, the last slide I will tackle. What is the best time to have deep brain stimulations? As Dr. Rodriguez said, this is not a treatment of last resort. So not after your doctors are so done with you that they've tried everything from A to Z. In fact, one study not too long ago showed, comparing, patients with best medical therapy versus early DBS. When I say early DBS, within the first couple of years of diagnosis. And what they found that, long-term patients with that had early DBS seem to fare better than those that were put on best medical therapy. Although for now, we don't do DBS yet in the earliest stages, except for a few exceptions. So for advanced patients with more advanced disease, we look for motor fluctuations and dyskinesias. And then Dr. Rodriguez used a rule of 5. I'm a little bit more aggressive. I use a rule of 3 or more, especially if they have side effects. The moment that they have side effects to 3 or more, I don't try to push for 4 or 5. That more or less is my threshold. Also, if they're a very strong tremor and they're not tolerating the anticholinergic drug that Dr. Rodriguez mentioned, and they're not they're not responding to high doses of levodopa up to 900 milligrams, if not more, and then you try to do the combination of these drugs with dopamine agonists and amantadine and anticholinergic drugs. If they truly have strong tremor, they earn a ticket to early DBS. And then I also try to think about DBS in patients that are starting to get a little old, because I kind of counsel my patients, don't miss the boat. Because one thing you don't want is be above 80 or sometimes even in your late 70s, and the doctor is saying, well, now you're too old, you're too demented, you're too sick, you're not a blood thinner, you just had a stroke, now you have cancer, then you miss the boat. So whenever I have an indication for Parkinson's medicine, where it be poor tolerance of Parkinson's medicine, strong tremor, polypharmacy, motor fluctuation and dyskinesias, even within the first 5 years, whenever I see these indications, I kind of say, okay, maybe let's plant the seeds for DBS and let's start thinking about this. Do you have any strong feelings about what I just said, Dr. Rodriguez, one way or the other?
I agree with you. I think that, basically, just like in the comment I made, many people wait just too long, and that boss leaves, and then there will not be a candidate. So the main goal is to keep your good quality of life. And once again, you're younger today than what you will be tomorrow. So you should be able to tolerate the surgery better today than what you will tolerate it tomorrow. So don't try to delay this, because some people will meet that endpoint and should not be delayed.
Okay, we're running out of time. 1 minute response from you. When do you push for focused ultrasound for Parkinson's?
I only push for focused ultrasound in people that have bad tremors associated with their Parkinson's disease, and they're not good surgical candidate for deep brain stimulation, and they have not responded to medicines.
And do you have patients with focused ultrasound where the tremor improve and then they develop symptoms in the other side, or more Parkinson's symptoms outside of tremor, and therefore they now need deep brain stimulation on top of focused ultrasound?
Yes, I had somebody that is in that point where discussing that issue, whether she would be a good candidate or not. She's a young lady, might be a candidate, but we are talking about it.
And can you do focus ultrasound in both sides of the brain?
No, I wouldn't recommend it.
Okay, I echo his opinion 100%. Okay, so I usually reserve focus ultrasound for those with very severe tremor and they don't want surgery, or they're not good surgical candidate. It's one side, and it's one-sided. They have no, severe tremors in the other side. If you have midline tremors like your head, your voice, or your trunk, you need both sides done, and certainly you cannot do focus ultrasound on both sides. Okay, so thank you very much, Dr. Rodriguez. It's been very educational to myself and to the audience. Thank you for all your insights. And we hope to get you back in the future. And then I'm going to turn now the floor back to Taylor.